part of the lung will be affected and it's collapsed and it's consolidated, so you have only little room for ventilating. And lung immaturity, neonatal and preterm babies. And in addition, a lung is already injured, okay, because maybe because of aspiration, drowning, okay. So any of these three determinants can also aggravate development of ventilator-associated lung injury. So we have to know how to prevent our lung from ventilator-associated lung injury. So what are the manuals we do to prevent our lung from ventilator-associated lung injury? So most of the art you should be able to understand, right? So this is a PV loop, the pressure volume loop, and also called as compliance curve, right? So what is in the x-axis is the pressure, and the y-axis is the volume. So when you increase the pressure, there should be increase in the volume, right? So it's called as delta V by delta P. So change in the volume per unit change in the pressure. Whenever you change the pressure, whenever you increase the pressure from 2, 5, 10, there should be increase in the volume. So that's called as compliance. Okay? So you have two areas in the compliance curve. Is the lower inflection point and higher inflection point. So lower inflection point is the point where your alveoli start to open. Okay? So it's a closure pressure. So after that, your alveoli is going to open. Okay? And higher inflection point is the point where your alveoli is fully open. So after that, even you increase the pressure, there will not be any increase in the tidal volume, but it will cause rupture of the alveoli. Okay? So you must be able to understand where is your LIP and where is your HIP. Okay? So you can see here, so after the alveoli is during the LIP, okay, or below the LIP, we call as low volume or low lung volume. So in the low lung volume, your alveoli are more prone for atelectasis, where if you ventilate a patient in the high lung volume, there is a more chance of getting rupture. Okay, so where you want to ventilate is in the safest zone. Okay, so atelectrauma and the zone of safe. Okay, this is the area where most of us, our ventilator strategies are working on. So lung protective ventilation is working in between because you decrease the tidal volume and decrease the transpulmonary pressure. Your airway pressure release ventilation is working in the safe zone, because in the airway pressure ventilation you don't use a lot of tidal volume. Okay, you use minimal pressures. Okay, and also high frequency is one of the great example of ventilating in the safest zone. Okay, so we all believe that high frequency is delivering high pressures, right? So it's delivering very low tidal volume with safest pressure. Okay, so zone of safe. So how we prevent ventilator-associated lung injury is simply, we know the mechanism, right? So how ventilator-associated lung injury has developed. So just prevent them or break the cycle of ventilator-associated lung injury, the mechanism. So there are two mechanisms, as I told you, prevent over-distension and prevent cyclical atelectasis. And third thing is the biotrauma. So there were a lot of research going on about anti-mediator therapy or anti-inflammatory therapy for treatment of biotrauma. It's all in the trial phase. So as an RT, it's very important for us to know by two methods. To prevent the over-distension, how we prevent over-distension? By decreasing the tidal volume and decreasing the platelet pressure. Okay? Preventing the cyclical atelectasis by maintaining adequate PEEP and recruitment manner. So recruitment manner has role in decreasing the cyclical atelectasis. Okay? So how you prevent over-distension is by low tidal volume. So what is the tidal volume? Effective is, as all of us know, that 6 ml per kilogram of body weight. Any patients, either ARDS or non-ARDS, so we suggest to start with 6 ml per kg per predictive body weight. Okay, then look at the patient plateau. Okay, so if the patient plateau is less than 30, you can continue the same ventilator strategy. If a patient plateau is going beyond 30 centimeters of water, that's the time you have to decrease the tidal volume 1 ml per kilogram of body weight. So no need to confuse. So any patients, So either ARDS or any patients who come and freshly intubated, just start with 6 ml per kilogram of body weight. Then depends on the patient plateau pressure, you can decrease the tidal volume still. Okay. And yearly adherence, there is a study also says that yearly adherence to low tidal volume relation improves outcome and mortality in ARDS. Okay, and also non-ARDS who adhere to low tidal volume ventilation decrease the risk of developing ARDS to the patients. Okay, that's why we suggest to have a low tidal volume for all patients, irrespective of AEs and ARDS or pulmonary edema or COPD and asthma. So because it's shown to be decrease in the mortality and fewer pulmonary infection and less atelectasis. Okay, so clear with the low tidal volume. If you have any doubt in applying low tidal volume to a patient. So this is from ARDS net actually. So decrease in the tidal volume will decrease the 22% mortality and increase the number of ventilator-free days. Okay, this was from the ARDS network. So the next is next component of overdistension is plateau pressure, right? So you wanted to decrease the plateau pressure. So low plateau pressures are associated with the less alveolar overdistension. So your target is to keep the plateau pressure between 28 to 30. So you must understand that it's not a threshold variable, meaning that you should not always keep 28 to 30. As low as possible will be always better. Okay, so lower your plateau pressure, so higher the patient, lesser the chance of developing lung injury. Okay, so when plateau pressure equals or exceed this pressure, tidal volume can be decreased. Simple. Okay, so our target of the plateau pressure release in any case it should not be exceed more than 28 to 30. Okay, so always look at the plateau and keep it as low as possible because it's not a threshold variable, it's a continuous variable where you have to continuously monitor and keep your plateau pressure at the lowest level. And whenever the plateau pressure reaches the level of 28, so start decreasing the tidal volume. Okay, so one of the consequences of decreasing tidal volume will be the PCO2 buildup. Okay, the permissive hypercapnia is allowed and it will do no harm compared to hypoxia. Right? So because most of what hypercapnia can do is, if a patient is not an increase in ICP or pulmonary hypertension, the simply increase in the PCO2 will just cause narcosis. We call it CO2 narcosis. All of our patient is in the ventilator. Okay, so no problem to bother about CO2 or narcosis. Okay, so unless your patient has an acute increase in ICP, you should be controlling your CO2. So this is the evidence compared to two groups, 6 ml and 12 ml with different pressure, 30 and plateau greater than 30. So shown that plateau less than 30 group has higher mortality, lower mortality than the plateau more than 30 ml, 30 centimeter water. So the next component of preventing the cyclical, next component is preventing the cyclical atelectasis. So how you prevent cyclical atelectasis is by keeping a PEEP. Okay, so PEEP has a protecting effect. Okay, so it has a protecting effect by avoiding a repetitive alveolar opening and collapse at the low lung volume. So when you keep a PEEP, so your tidal volume will also be distributed equally. So an optimal level of PEEP has not been established. We don't know exactly, as like a plateau pressure, we can say that plateau pressure 28 to 30 is safest. So more than 30 is not safe. But in the PEEP, we don't know which PEEP is safest. Okay, which PEEP is unsafe. It's all depend on the patient. Okay, because even in the ARDS patient itself, we have two kind of ARDS, extrapulmonary and pulmonary. So extrapulmonary ARDS patient responds to the PEEP well compared to intrapulmonary ARDS. Okay, so there are a lot of differences in the PEEP between the patient groups. So an optimal level of PEEP has not been established, and higher PEEP should be make the mechanical ventilation less dangerous than lower PEEP. So having a little higher level of PEEP is always safer than having lower level of PEEP in patients with the ARDS. Okay, so either how you select a PEEP, how you normally select a PEEP, you just start with 5. Okay, so when you go up with the PEEP, Suppose your patient is in ARDS, he's developing ARDS, so patient is getting desaturation. So when you need to increase the PEEP, yeah, we know that it's increased oxygenation. So at what time you decide to increase the PEEP? Yeah, that's a good answer. So when you reach an FiO2 at 60%, so a patient is still hypoxic, okay, that's the time you have to start increasing the PEEP, okay. So there are different methods of selecting an optimal PEEP, okay. So either by doing a recruitment, okay, so you can simply put a patient on pressure control ventilation, set a PEEP of 20, and you should sedate and relax the patient before doing the recruitment maneuver. So put a patient in a pressure control ventilation, give a PEEP of 20, and give a plateau pressure of 50. Okay, okay. So in that, ventilate for 2 minutes. Okay, then decrease the plateau pressure back to safest limit, that is 30 centimeters of water. So after that, decrease your PEEP 1 ml, 1 centimeter of water every 5 minutes. Okay, decrease your PEEP. Okay, 1 centimeter every 5 minutes. There are two techniques you can observe, either by observing the ABG or oxygenation, or observing the compliance. While you're decreasing the PEEP, either observe oxygenation or compliance. Oxygenation can be observed by ABG every hourly. It's very difficult. So doing ABG every 5 minutes, meaning every 1 centimeter you drop, you should take an ABG. So it's not possible actually. So compliance method, so watch your compliance and watch your tidal volume while you're decreasing the PEEP, okay? So whenever you drop the tidal volume while you're decreasing the PEEP, okay, so that's the closing volume. That's the time your alveoli is closing. So you should add 2 centimeter above the closing volume, meaning you add 2 centimeter of that PEEP, okay, to add for suppose you're decreasing from 20 centimeter, at 10 centimeter of water, you drop tidal volume. Okay, so at that time you increase 2 centimeters, so set a PEEP of 12. Okay, this is a selection of optimal PEEP. Okay, so also you can use a PEEP FiO2 table that given by ARDS net trial. If you download an ARDS net recommendations, a single paper, it tells you how to decrease bladder pressure, how to set a predicted body weight, how to set a tidal volume, and also it has given a table called PEEP FiO2 table. So at what FiO2, which PEEP will be a good combination. Okay, you can also use that table to select your PEEP. So don't blindly select PEEP, especially in patients with ARDS. So there are also good and bad of PEEP. So you should be aware that PEEP is increasing the over distension. It opens the alveoli, it prevents the collapse during exhalation. Okay, so it prevents the collapse of alveoli during exhalation, but also it can sometimes cause an over distension. Okay, so that's happened mainly in patients with asthma, where they have an occult PEEP or intrinsic PEEP. Okay, which increase the intrinsic PEEP, which causes hemodynamic compromise, and also it's decrease the sensitivity of triggering in the ventilation. So the study says compares between the patient with ARDS and patient with non-ARDS, without ARDS. They compare high PEEP and low PEEP in the two groups. They found that benefits from higher PEEP for ARDS. So we always keep higher PEEP in the ARDS will be beneficial, but acute lung injury without ARDS, okay, no benefit, or even they found some harm of applying higher PEEP in patient without ARDS. Understand? So what are the other techniques? You can tell us open lung ventilation. Okay, so it's a good example of open lung ventilation. Okay, you give very low tidal volume, that is typical dead space, less than 150 ml, with high PEEP. So you maintain the alveolar recruitment, at the same time you decrease the tidal volume to the patient. And the next thing is, on the high frequency is, you are not opening and collapsing the alveoli, right? Your alveoli will be distended, okay? So by applying hits, it will be only vibrating. So it will not open and collapse. So it did not apply high tidal volume, it did not give high transpermeable pressure, it did not repeatedly opening and collapsing the alveoli. So that's why most of the high frequency patients, we don't see lung injury actually. So that's open lung ventilation. So PEEP above LIP, so that's how you use, or you can use sometimes recruitment maneuver. So open lung ventilation can be also with the recruitment maneuver. Okay, so even in the high frequency, we do recruitment maneuver before hooking to the patient in high frequency ventilation. Also, you have to consider proning and high frequency. So prone ventilation is a kind of protective ventilation because in the ARDS patient, when you prone, okay, so we know that the dorsal lung regions are more prone for collapse. Okay, when the patient lying in the supine, okay, your air will be tended to stay in the upside. Okay, whatever the oxygen goes, it goes to the ventral region. Okay, so it will be ventilated, and the dorsal region is perfused well. It's compressed by the weight of the heart, and also the patient is lying. Dorsal lung regions are more prone for ARDS. So whenever you apply tidal volume, so it only goes to the ventral region. Okay, where there is an so what will happen? So when more tidal volume is given to the ventral region, so there will be more chance of rupture of the alveolus in the ventral region. So that's why we prone the patient to equally distribute the ventilation and perfusion. Okay, because in the ventral region there is a good ventilation. Whatever you give, the tidal volume goes to the ventral region, but the blood is stayed in the dorsal region. So high VQ mismatch. Patient. Okay, it releases the mediastinal weight on the patient lung, dorsal lung, so it opens the alveoli, and the tidal volume you given will be equally distributed to the ventral region and the dorsal region as well. Also, it decreases the VQ mismatch. So this is how the proning act as a lung protective ventilation. Also, in the proning, if you give tidal volume more, it less likely to injure lung than the supine. Understand? Also high frequency, I discussed about the high frequency and how it comes under the open lung ventilation. So that's all about the techniques how to prevent the ventilator associated lung injury. So I wanted to summarize by giving an important message like do less harm to your patients. Okay, so a patient at any time during the mechanical ventilation can buy the mechanical ventilation itself. So we should be careful in selecting a tidal volume, pressure, okay, the flow ratio even you said, okay, so also very important. So always do less harm to the patient by selecting appropriate ventilator parameters. So have an optimal PEEP. So don't set PEEP blindly like 5 or increase to 7, 10, 12 without knowing what's your patient tidal volume, what's your patient compliance, what's your patient oxygenation. Okay, always follow a protocol for incrementing the PEEP. And low tidal volume for all patients, irrespective of the patient's lung pathology, start with low tidal volume, 6 ml per kilogram. So use a high PEEP combination in patient, especially with the ARDS. If a patient is ARDS, 100% you get desaturations up. So don't blindly increase the FiO2 more than non-toxic level. Try to have a PEEP and FiO2. Then permissive hypercapnia. As I told you, don't afraid of seeing a PCO2 of 60 or 70 or 80